Now for our last talk, it's a pleasure to invite Dr. Albert AlAhmar, who is a consultant interventional cardiologist in Dr. Sulaiman Al Habib Hospital in Dubai, who will touch upon the mechanical support in cardiogenic shock.
Thank you very much, Professor Musa, to the panelists, to the GIS panel. It's a great pleasure to be here among you. And I'm aware of the fact that we are close to the lunchtime and praying time, so I'll try to keep on time. Before I start, I couldn't resist put this slide on. As you all seen recently, I think Dr. Hani probably will highlight this as well. In the Times recently, Leicester University has overtaken Oxford in medical research. And I have the pleasure to have a couple of publications under the name of the university. This is the outline. I've had the job of just talking about hemodynamic support evidence, and I think my previous speaker elegantly highlighted the facts. I think if any message we're going to take from this, you better put your mechanical support as soon as you hit your patients diagnosed with cardiogenic shock before you touch the coronaries. The cardiogenic shock definition, I think we've all touched on it, but I think the definition still remains outstanding from the 2016 publication by Atkinson and Jack, defining the parameters for cardiogenic shock. And I would highlight here the hemodynamic part. There is more emphasis nowadays to be invasive on monitoring your patient's pressures, particularly the cardiac index and the wedge pressure. The status that your definite diagnosis is when your cardiac index patient is less than 2.2 mil per minute per square meter and wedge pressure is above 15. The SCAI, I'll highlight the pyramids of the SCAI without going into details on this one, but as you can see, you need to highlight those sick patients as early as possible. They are, the first line in the pyramid is the baseline, is at risk. When you see these parameters here, the cardiac index is more than 2.5. When they start to close to 2.2, your patients will start to deteriorating. And once they're less than 2.2, they are definitely in cardiogenic shock. Mortality-wise, we're all aware of the fact how serious this condition and how sick those patients. But as you've seen before, more than 50% they die in hospital. 1 in 2, those patients, they don't survive in hospital. Not only that, those patients, even 60 days, and we have data on 6 years now, they remain high risk for mortality. The 10% of them, 1 in 10, will die after discharge. So we lose half of them as in hospital, and we lose 1 in 10 in the next 60 days. So we have to take very good care and a teamwork in order to look after this very sick group of patients. The incidence, unfortunately, is not slowing down. As we are all aware, it's growing day by day. The solid registry that I've seen increase 53% in ischemic cardiogenic shock is from this publication. This is back from comparing 2010 to 2014, and the number in the United States alone exceeds 55,000 patients per annum. The data behind and the research evidence is patchy, and we all know why. The reason is it's hard to recruit those very ill patients into any randomized trials. And you can see here from this table how many trials they've been discontinued due to the fact it wasn't possible to continue recruiting. Imagine your patient coming to you with a blood pressure 40 in the emergency room, and you want to ask your research nurse to randomize this patient between A device or B device. I think that will be hard to conduct. However, I think as in the Acuity trial, as an example, we know that they've bypassed all sorts of ethical approvals to recruit patients into the trial without even consenting, without even using any kind of, apart from just flipping the coin and decide which one That's how they included everyone. And I think we need a trial like this to look at those patients to decide which device we should be using. Within the patchy evidence, I'll just show you briefly what we have so far in terms of data. The devices that we have, that as we all familiar, perhaps we all familiar with the balloon pump, and indeed a lot of us with Impella. The tandem heart and ECMO, as you can see, the parameters, given the complex pathophysiology of the cardiogenic shock, you need to improve particularly the parameters of end-diastolic pressure, microcirculation, preload and afterloads. If you look at the tandem at heart and ECMO, certainly they don't fit the criteria as per the first two devices. Indeed, most Impella devices in terms of vascular access, they do, if you are not using the Impella 5, which is quite often not used, we use the 2.5, it's 13 to 14 French. So it's not a massive device in terms of access. And quite often you've seen that rather than the femoral artery access, has been used axillary one or even subclavian. So we can fairly say that perhaps we're going to focus on the intra-aortic balloon pump and the Impella device. Well, the main two trials, as we've seen already in my previous speaker, looking at the balloon pump impact in acute MI cardiogenic shock are the SHOCK 1 and the SHOCK 2 trials. The SHOCK 1 was very small sample, as you can see, total 40 patients, randomized between balloon pump and medical therapy. And statistically, there was no significant difference between the two arms in terms of 96 hours. The SHOCK 2 trial was reasonable size trial, recruiting 600 patients into intra-aortic balloon pump arm and medical therapy. And as you can see, 60 days down the line, there was no significant difference between the two arms. And I think the general consensus among most of us is at that point that we should not be using intra-aortic balloon pump. However, we're all familiar with the fact that there has been a lot of criticism for the SHOCK 2 trial since the balloon pump was inserted quite late. And I won't go through that details, but there are some meta-analysis looking at the time scale of inserting the balloon pump in the SHOCK 2 trial. And the mean time in this one is 24 hours. So we're already late in terms of inserting the balloon pump. I think there is a big shout for a trial recruiting those patients, inserting the balloon pump as soon as we make the diagnosis. This is just an example, a case, we all do it. This is a patient, younger chap, coming with cardiogenic shock, arrested in ER. And as you can see, the first thing we've used is a balloon pump through his left femoral artery, and we access the rest via the right femoral artery. Luckily, this guy, he was one of the 50%, the other 50%, and he survived, went home after 10 days on ICU. Impella, certainly it's a promising technology, and it has a lot of support behind it, particularly in the USA. I'll read for you just the FDA statement published saying that the Impella 2.5, all type of Impella, including 5 and Impella LD catheters, in conjunction with the automated Impella controller console, are intended for short-limb use. This, basically, the FDA has approved the use of Impella in patients with cardiogenic shock complicating acute myocardial infarction. Where did the data come from for the FDA to use it? As you can see in the upper half of this table, this is what they used basically. It is a little bit patchy for the FDA to approve such a device in this category. The first one is RECOVER-1 FDA-driven study, whereas the number of patients is only 17 patients. So it's a very small sample size. The IZAR Shock RCT trial, look at the number of patients, 26 patients, 13 of them had Impella device. The US Impella registry had 400 patients. They all had the impeller, obviously, and it was used to approve the device. They reviewed the literature, and they shown they can find 2,500 patients. Of those, around 700 patients had impeller inserted. And they've analyzed this data, and the next thing is approval by the FDA for using impeller in this group of patients. I'll leave you to judge what you think about this. The population studies showed reduced mortality with percutaneous VAD, which is primarily, it's the impeller actually in cardiogenic shock. And as you can see, the mortality data in this, you can see it drop from 52% to 43%. The mortality in acute cardiogenic shock using ECMO /forward LVD, this is not a randomized trial, versus percutaneous VAD has showed significant favor in terms of using the percutaneous VAD. And the number of patients over at 1,100 patients. I'm sure we're all familiar with the impeller, and I don't need to go through this, but as you can see, the LVADP, the wall tension, the myocardial resistance, the microvascular resistance, the coronary flow, all that will improve as a result of inserting it's as simple as it can be inserting a device. I think the main issue with the impeller is the vascular access. IMPRESS trial, we're all familiar with this, where it randomized patient between impeller, CP, and intra-aortic balloon pump. However, this publication in 2017 didn't show any difference between the two mechanical support devices. So I think the evidence behind the impeller is not compelling yet, and the jury's still out to decide whether or not we should be using it up front. As you've seen in terms of using early, can I just have 1 minute for my conclusion slide?
Yeah. Give him 1 minute, please. Sure.
I cannot move my slide, please.
Okay. Okay.
I'll move to just perhaps for the conclusion. I think there are some algorithm in the guidelines in terms of when to use it, which device to use, and it's quite complicated. Nonetheless, what I want you to take home message is cardiogenic shock remains lethal. Early revasc improves survival, mechanical circulatory support as soon as possible, and certainly is redefining the treatment paradigm. We need more randomized controlled trials data to evaluate what device and when to use it, the timing scale. Thank you very much.
Thank you very much, Dr. Albert Hammer, for the nice presentation on the mechanical support. If I take final comments from our dear panelists on the Dr. Hani tape, if you want to comment.
With your permission, there is... Yeah. Okay. I think one important point that you made, Albert, is how tough randomized trials are to conduct in this group of patients. We did the randomized trial culprit shock, and we were praying God that it is culprit vessel only, because the moment that you start doing that. So nonetheless, without trials, we're a bit in the dark.
Since we are talking about support devices and impeller, my question to you, what is the most appropriate time or will impeller be used in a patient with high-risk multivessel PCI? I mean, we know that it is the evidence for it in a patient with cardiogenic shock and deteriorating patient. But what's your advice about using this device in a patient with high-risk, low EF, multivessel PCI, when to use it? If you can give us, like, a couple of insight about that.
Yes, sorry, apology. I didn't get the question. What's the device we're talking about? Mechanical support, or are we talking about
mechanical
specific
support,
device?
like an impeller.
So From the data that I've shown you, as I said to you, again, the data is quite patchy given the difficulty in recruiting patients. However,
No, I'm talking about stable patient, not cardiogenic shock. You understand?
So you want about stable patients?
Yes, a stable patient.
So somebody with acute MI in your ER, what to do?
Not even acute MI. Patient coming to your cath lab with high risk PCI, low EF. What is, in your, I mean, in line of your talk, what's your advice about using those devices?
I think we've seen quite a number of perhaps the mechanical support. When the LV is down, I think there is more trend nowadays to use perhaps some device with mechanical support. And Impella is proving day after day easy to use. In the right hands, it's very safe with vascular access. So I think my take on this one, the stable patients with low ejection fraction, multi-vessel device, if you use the hemodynamic support up front, it makes your life in the cath lab much easier and helps you address your lesions easier and reduce the ischemia burden. As you've seen yesterday from Mount Sinai, the case where the patient was overly sick. She was elderly, she had every factor under the sun to say this is a very high-risk case, and the Impella made it very simple case without any hemodynamic compromise throughout the case.
Great, but some people can argue with you that, well, this is a very expensive device, and is it cost-effective to...
It's worth it, 100%, it's worth it. Sure. I mean, you talk about patients' life here, definitely. But I think this is another topic for talk about it, and it's a fascinating topic indeed.
Professor Colombo, if you want to comment, please, go ahead.
Regarding low ejection fraction patient elective, I think we tend to overuse revascularization in these patients because unless we have a clear indication of ischemia, the improvement is minimal or absent, and sometimes they pay additional price in peri-procedural MI. So I think elective PCI in low ejection fraction patient should be clearly defined case by case.
Absolutely. We tailor the treatment based on individual patients. I mean, the clinical scenario, the age, every part, renal function, they should be taken into consideration.
Dr. Albert, thank you very much for your presentation, and I would like to conclude this section of acute coronary syndrome. And special thanks to our dear panelists, Dr. Mohammed Zbeid, Dr. Hani Ateba, Dr. Ibrahim Rajdan, Dr. Naif Asiri, and last but not least, Dr. Abdul Majid Zbeidi. Thank you very much, and I will conclude the session. Thank you.